So our speakers are Pronita Raha, Joy Kemp, and Judith McAra-Couper. So Pronita Raha is a program analyst midwifery, currently working at UNFPA Bangladesh. She served for more than 25 years as a clinical practitioner in different disciplines of Bangladesh nursing services, including 5 years as an educator at Dhaka Nursing College. Pronita has been serving UNFPA Bangladesh for 7 years as a national midwifery officer. And program analyst midwifery, holding a leading position in strengthening the midwifery profession in Bangladesh. Pronita was awarded as an international midwife, sponsored by the International Confederation of Midwives and Save the Children International at the 30th Triennial Congress in 2014, in recognition of their contribution to promoting midwifery education and services in Bangladesh. Pronita's major contribution to provide support and guidance for the development of various policy documents for the midwives and curriculum for the different level of midwifery educational program in Bangladesh. Pronita has completed a BSc in Public Health Nursing from the University of Dhaka and a Bachelor of Arts from the National University. She also pursued her master's in Advanced Midwifery from Prince of Songkla University, Thailand, and a master's in Sexual and Reproductive Health and Rights from Dalarna University, Sweden. She has undergone different long and short-term training programs for the development of a professional career at home and abroad, and her dedication lies in promoting midwifery as a distinct profession in Bangladesh to save the lives of women and newborns. Joy Kemp is a midwife from the United Kingdom and is currently serving as an international midwife specialist with the United Nations in Bangladesh, a climate vulnerable country where professional midwives recently been introduced. From 2013 to 2023, she was global professional advisor for the Royal College of Midwives and had an academic career as a senior lecturer, program director, and researcher, as well as clinical midwife in the UK. Joy's humanitarian work spans over 3 decades, focusing on maternal and newborn health services for vulnerable population in challenging and fragile settings worldwide. Joy's significant contribution to the midwifery knowledge includes the capacity building of professional midwives associations, enabling them to develop the organizational structures and systems they need to serve their members and position and equip midwives for their pivotal role in sexual, reproductive, maternal, newborn, and adolescent health and gender equality. Joy is lead author of the book Global Midwifery, Principles, Policy, and Practice, and has contributed to many other publications. Joy's personal experience with dyslexia has led her to take a special interest in supporting neurodiverse midwives and others in achieving career success. And lastly, Judith. Judith's midwifery experience began at St. Helens and Middlemore Hospitals in Auckland, New Zealand. Then followed 6 years working in a village in Bangladesh. Since 1998, she has worked at Auckland University of Technology as a midwifery lecturer and held a joint appointment at Counties Manukau for 12 years as clinical midwife educator in the delivery unit. She completed a PhD in 2007. In 2009, the World Health Organization Bangladesh employed her to write a midwifery curriculum and syllabus for nurse midwives. She has returned to Bangladesh many times, employed by UNFPA Bangladesh to facilitate the implementation of the program, along with the curriculum development for direct entry midwifery in Bangladesh and faculty development and education. She was awarded a postdoctoral scholarship in 2010, and her research interests involve maternal mental health, sustainability midwifery practice, preterm birth and maternity service, and equity outcomes. She was the chairperson of the Auckland region of NSCOM from 2008 to 2011, was appointed to the Midwifery Council of New Zealand in 2010, was the chair of the Midwifery Council from 2011 to 2018. She became head of midwifery department at AUT in 2013, and associate professor, sorry, in 2014, and a professor in 2020. She's head of school clinical sciences at AUT. She's passionate about midwifery education, equity, good governance of midwifery organizations, and learning how to be a better Tauiwi Tiriti partner in Aotearoa. Thank you so much. Sorry for taking longer than expected, and I'll leave it to you.
Thank you so much. If we could go to the next slide. Thank you.
Mm-hmm.
So we're going to start our presentation with background and setting the scene. So Bangladesh has undertaken an amazing journey in the last 15 years to move from having no midwives as defined by ICM to launching midwifery as a new profession in 2010, to a 3-year diploma in midwifery commencing in 2013, to a bachelor's in 2022, and now a master's in midwifery starting in 2026. I was privileged to be part of this journey from 2009 to 2021. This journey has always been driven by nurse midwives and midwives in Bangladesh wanting to make a difference to women, people, families, and communities. And this is nowhere more clearly seen than in the reduction of maternal mortality, which at present is 136 per 100,000, remembering the target is less than 70 per 100,000 from the Sustainable Development Goals. A publication on the impact of skilled midwives on saving maternal and newborn lives in Bangladesh, which used the Lives Saved tool developed by Johns Hopkins, showed through modelling that where 75% of birthing happened in facilities and where 100% of those facilities in Bangladesh could offer midwifery-led care, a further 31,000 plus maternal and newborn lives could be saved by 2035 in Bangladesh. This, of course, requires the ongoing commitment to upscale midwifery education and services across Bangladesh, and this cannot happen without faculty to teach students and mentor educators, which leads nicely into the next slide of faculty development. Faculty development in Bangladesh has been a multi-pronged strategy over many years. The peer mentorship program is just one aspect of UNFPA's long history of supporting midwifery education and developing faculty since 2010. While the ICM global standards for midwifery education state that midwifery faculty should be licensed registered midwives, but when the midwifery program started in Bangladesh, there were no licensed midwives. So there was not only a question about who would mentor the faculty, but who would the faculty be? And I know many other countries across the globe have found themselves in this sort of situation. In the beginning, nurse midwives were given an additional training in midwifery just to equip them to teach the new midwifery curriculum. So in fact, 1,600 nurse midwives did an additional 6 months midwifery on top of their existing 3 years of nursing and 1 year midwifery course. And they became what is known as certified midwives. And these certified midwives became the first midwifery faculty. This has been followed by 150 nurse midwives who were then enrolled in a Masters of Sexual and Reproductive Health with Dalana University. So, and Bangladesh's commitment to meet the health needs of the country meant that in 2020, when the diploma curriculum was reviewed, 28 new midwifery schools were open, which meant that these new and existing faculty required support and mentorship. So the next slide, please. So this, of course, led to what are the ways in which we can mentor and educate new faculty? And one of the ways in which we can do this, of course, is peer mentorship. So a little bit of background to this peer mentorship program. This program began in 2021, and this was delayed due to COVID-19. And it was developed to support midwifery teachers in the 62 midwifery education, public education institutions. And this program is still ongoing. For me personally, this peer mentorship program was an important milestone as it begins the move away from mentorship for faculty being provided by international faculty to national faculty, as there were and are a good number of educated, experienced, a good number of experienced midwifery educators in Bangladesh now. So, of course, the question is, why peer mentorship? Most literature on faculty development, of course, identifies membership as being an important component of developing faculty. But traditional membership is usually given by someone senior to someone junior and has that traditional power differential and often imbalance in it. Whereas peer mentorship is less hierarchical. Two people at a similar level in their career offer each other support and guidance, and it's reciprocal, which is such an important aspect in peer mentorship. But of course, for us in midwifery, where both the mentor and the mentee benefit from the relationship. Peer mentorship is also felt to be particularly suited to mid-level faculty and those facing transitions, and in this case, the transition from teaching nursing to teaching midwifery. Remember, when you did not have any licensed midwives, as when we think of midwives these days. So there was a transition from teaching nursing to teaching midwifery, and a very different approach to teaching. And this is why peer mentorship is such a good model for Bangladesh. Next slide. So keeping all this in mind, in 2024, UNFPA conducted a process evaluation to understand how the peer mentorship program was being delivered across Bangladesh. Process evaluation is informed by more was an appropriate methodology for this, as it focuses on the processes and activities involved in implementing an intervention, which in this case was the peer mentoring program. It provides data for us on what works well, what doesn't, and why. And it also takes into account the context, implementation, impact of the program, and of course the outcomes of the program. This means the facilitators and barriers to success can be clearly identified, as well as the impact and outcomes. This is really important when there is a program or intervention such as the peer mentoring program, where you may want to further scale it up or replicate it. So this was a very appropriate methodology for undertaking this evaluation. Next slide, thank you. In this slide, we just want to provide some information about the intervention and the assumptions that inform process evaluation. Experienced faculty were selected as peer mentors, and they received the training and education. This was initially planned to be face-to-face, but COVID-19 necessitated a change to online teaching. And so this was online teaching with clinical skills practice videoed and critiqued. And as one of the people leading this, we were uncertain, would this work, wouldn't this work, what would this look like? And so many great learnings for all of us. And this did really work. And we had some very unexpected outcomes from this. So it was a very exciting time in my life as an educator. Stakeholder engagement was critical in developing this program, as was policy leaders. Stakeholders were involved in the design and the implementation, including the Directorate General of Nursing and Midwifery, Bangladesh, the Bangladesh Nursing and Midwifery Council, and the Bangladesh Midwifery Society. An important part of a process evaluation is that it makes transparent the theories underpinning the project and the assumptions about what change would the intervention bring. So what changes would the peer mentorship program bring? So the primary assumption that underlaid the evaluation was that the peer mentorship program meant that faculty would be enabled to teach the curriculum using participatory, non-didactic teaching methods, which would result in more competent midwives. And our secondary assumption was that there would be a development of a national community of practice. So let's see how this unfolded. And I'm now going to hand over to my colleague, Pronita.
I'm audible.
Yes.
So I'd like to continue the selection process for the peer mentors, how Bangladesh select the peer mentors from the different regions of the country. You can see in the right sides in the map, the Bangladesh map, there is the 8 divisions. So first of all, we select the peer mentor from all the divisions. They must have to cover all the divisions, the 8 divisions from the Bangladesh. And so we select the 20 faculty from all over the country. And the peer mentors, we follow some criteria to be a mentors. Among them, the 3 years teaching experience they need, and also they have to 10 years the clinical experience, and preferably they should have the certified midwife course completed, the certified midwife, and also Judith mentioned about the SRSR faculty, master's faculty would be preferable for the mentorship program. And they should have completed the TOT program, that is the 28 days program, though most of the faculty completed this program for the curriculum development and the curriculum implementations. And the most significant criteria was the peer mentors are willing to travel to the others institutions to support the others faculty as a part of the mentorship program, because there is a lots of the family and personal issues may have with this. So they cannot move their family for 3 to 5 days or the 1 week to the others institutions. So this will be preferable that they are willing to support the others institutions. And also mentees have some criteria. The mentees should have the clinical experience, minimum 5 years, and also they have completed the foundation course for the teaching development foundation course, which was provided by the Bangladesh government. It was the 28 days course. So please, next slide, please. And the peer faculty, when they conducting the site visit, they using a checklist, a structured checklist, which is the existing checklist, but we revise this checklist as per the WHO midwifery educator competencies, and so the others, the information that we needed for the curriculum is implemented properly and effectively. There was difference the components, including the educational institutional information, then academic environments, then the clinical sites and other administrative issues. And then we use the digital dashboard, all as per the parameters on the indicators of all checklists. There were 29 indicators. All these indicators, after collecting data from using the checklist, they can enter this data in the digital dashboard. And also in the middle of the program, we assess the principals, the perceptions, and the faculty, how this peer mentorship is going well. It was the survey questions to among the 62 midwifery educational institutions principals. So how they feel the peer mentorship program is benefited their institutions, their faculty and the students, and as well as student outcomes. So next slide, please. And during the data collection process, it's normally happened in the January 22 to December 2023. The peer mentor are visited to the others institutions for quarterly, and this institution assigned as per their geographical location. Each peer mentors have 2 to 3 institutions assigned to support them, and they are visited for 2 to 4 days with these institutions by the order of the Bangladesh, the Directorate General of Nursing and Midwifery. They issues it or GO for their travel to other institutions, and they visit these institutions. During this visit, they observe so many things as per the structure checklist that I mentioned. There are 29 the indicators, and including they observe the teaching, pedagogical skills of the teachers and their assessment procedures, and the learning environments within the schools, and also the clinical side. And during the visit, they also visit the midwifery late care units. There was every institutions have the midwifery late care, the clinical side, where is the sub-districts, the health facilities, where the midwives, the registered midwives are deployed, they are practicing. So the Bangladesh, the Nursing and Midwifery Council are allowed the midwifery students to visit these midwifery late care sites so that they can fulfill their clinical logbook requirement. And during the visit, the peer mentors also met the principals and the faculty as well as the students to validate the data that they found difference the or observational site visiting. And with the principals, they confirm about the teaching learning approach and the behavior of the institutions, that the principals are regularly meeting with the staff and they are coordinating with the clinical side. They are supporting the minimum logistics that the faculty and the student is needed, and others, the quality of midwifery educational indicators. And in the practical settings, the faculty also visited the academic and the teaching activities and the program administrations. And data collection is mentioned using the checklist, the structure checklist, and then after collected data every quarterly, they uploaded and they entered the data in the digital dashboard. Next slide, please. In terms of outcomes, when we analyze the qualitative data as per the dashboard, and we showed that the peer mentorship program is improving the curriculum implementation in all the selected parameters. And the most significantly is it's improved the students' clinical practice placements, and it was improved 33%. And also the midwifery skills lab, the library, computer lab, it is open the whole days when the midwives are students are needed them. And the students also have the access of internet connectivity. The faculty are compliance with the academic calendar. They are following regularly, and faculty are using the creative teaching learning methodology and assessment procedures, and the quality of clinical learning experience also among the 62 midwifery educational institutions. And also it has improved the coordination between the mentee in the different institutions and the mentors in the different institution, as well as the institution to institutions. So they are communicating regularly with the different aspect, and their coordination in the different the learning resources, and they need the difference the informations and update the curriculum implementation process, so they can easily communicate with the others institutions faculty and as well as the mentors and mentee both. Please next slide, please. And this, the quantitative data also supported the qualitative data also. When we collected data from the principals, the survey questions, the principals, most of the principals, they mentioned that the peer mentorship program is benefited for them. It is supporting the mentors of their other institutions. Their students are progressing their clinical learning experience, and they peer mentors are supporting them, the students, so where they needed the support, they identify the students' need, and they can support them in that way. Please, next slide, please. And in the outcome 3, improving the network and the knowledge exchange that I already mentioned, the peer mentors are open to discuss with the others faculty, with the others institutions, using the the social media, WhatsApp group, the messengers, the Facebook, and the telephonic conversations. There was sharing resources. They have the central the resource folder, how they will use this, utilize these resources, how they can find the resources. They can easily reach out to others mentors and the mentees, and they are the good collaborative approach, and the community was created. And this helped to facilitate the skills development both, and the reinforce the new creative pedagogies. And one mentors mentioned that it's developed our relationship with the others assigned colleagues, and it's developing bonding with mentors and faculty mentees of their assigned institutions. So peer faculty mentors exchange their knowledge to others faculty, and faculty easily share any information with their assigned mentors. So it's highlighted by the principals from the most of the educational institutions. Would you please, next slide? Yes. And also I mentioned that the community of midwifery educational practices developed during the COVID sessions. You know that the physical movement is very difficult. So the faculty developed, many of the faculty, the primary, they don't know to utilize the different platform in the digital learning process, but ultimately they learn is others from the different approaches in the Zoom meeting, in the how to use the messengers and the different group and the Google Meet, every social media they are access that times. So easily they can reach out to them. Is there any support they needed from the mentors and the mentees and the principals? They are communicating with others. So the telephone connection and the internet access, and also the national and international midwives are available to support the faculty. So these, the digital platforms, so easier for the faculties to reach out to others institutions, faculty, and sharing the experience teaching in their own institutions, and also sharing the resources is other. So this is, and also when they need the international expert support, they can easily connect with them. So thank you. Maybe the next slide. This slide, can I over to you, Joy, to explain the discussion, the facilitators and the barriers part?
Yes, thank you so much, Pronita, for explaining the implementation of the program and also the results. So good evening, everyone, or good morning or good afternoon. So now we are going to have some discussion or think about what are the important learnings that we can take away from this study. So first of all, and part of the process evaluation methodology is to look at the facilitators of success. So the primary facilitator of the success of this peer mentorship program was the fantastic willingness of all of the participants and the stakeholders to engage with the program and the community of practice. They soaked up the opportunity to have some support in their teaching, to learn new ways of teaching skills and new pedagogical methods, and just to have that support and that community of practice. Also important in facilitating the process was the technical expertise that was available through the international midwifery faculty. And there are a good handful of international midwives like Judith and myself and several others who have been involved for the long term in the development of midwifery in Bangladesh. And at the time, UNFPA also had 2 expert midwives based in Bangladesh. So although they were not directly involved in implementing the program, having that technical expertise and the flexibility of Judith and her colleagues when the orientation took place and it couldn't happen face-to-face because of COVID, to move the teaching online and to see how actually that was still, although challenging, effective in achieving the results. And of course, this program would not have been possible without the digital technologies that Pronita mentioned, that facilitated the international connections, but also the community of practice and the digital dashboard whereby the teachers could upload, that the mentors could upload the data from their site visits. And then, of course, money comes into it. So funding enabled the site visits and the participation of a specialized statistician who could help to analyze the data from the digital dashboard. These facilitators are very similar. If you look at the published literature on mentorship and peer mentorship, these are also the things that have been found to facilitate effective mentorship. So our experience was fairly typical. Thank you. Next slide, please. So as well as considering the facilitators, there were some blockers to success. We talked about the orientation that was planned in person but had to move online. That internet connectivity is so important, and also the time to commit to the program, but both of those were often in short supply. And of course, to undertake the site visits, peer mentors had to be absent from their own institutions. We didn't measure whether that had an impact, but we expect that it may have had a negative impact on the quality of the midwifery education in their own institutions, because midwife teachers are so few and far between in Bangladesh. And some of the senior faculty were resistant to new approaches. That's life. People don't always like change. And the peer mentors themselves were not equal in their experience and skills. And we found that some faculty really struggled with the digital aspect of the program because they didn't have those digital skills. Also at the beginning of the program, a private sector education provider had been expected to support the peer mentorship, but unfortunately they were not able to fulfill their commitment. And in the literature on mentorship, these factors are very typical, but there are also some other barriers which are mentioned, which if we had more time we could go into, but let's move on to the next slide. Thank you. So as Pronita has said, the checklist was loosely based on the WHO midwifery educator competencies, which you can see here on the slide. There are 8 of them. As you can see, one of them, number 8, is research. This intervention, this peer mentorship program, was really designed to enable the hands-on practical teaching of the curriculum. And there wasn't a needs assessment at the beginning of the process to see what the faculty development needs were. It was rather assumed what their needs would be based on these midwifery educator competencies, but actually research wasn't included in the content for the orientation program, nor the mentorship checklist. And this correlates with was a set of studies which have been done by Rachel Smith and colleagues, which shows that in this region, Asia and the Pacific region, midwifery faculty development programs are rarely based on identified need. They tend to just be delivered on what the facilitators think that the faculty are going to need. So that's an important learning. But apart from the research competency, we did find that in all of the other areas, the midwife teachers had developed their competence. Next slide, please. Thank you. So there were some limitations to this work. It was limited because it was being implemented by the Directorate General of Nursing and Midwifery, which is a government institution. It was limited to the government midwifery education institutions, the public schools, and not the private schools, although currently there are significantly more private schools than public. We have 109 private midwifery schools in Bangladesh and 62 public. So we can't assume that the same results would be true if it were implemented in the private sites. And we assumed that if the quality of teaching improved, the student outcomes would also improve, but we didn't measure that. So if people were going to replicate it, that might be something to consider. And as we said earlier, the impact of the programme on the mentor's own institutions wasn't measured. And I'm getting messages from the facilitators that we need to keep going, so I'm mindful of that. The checklist hadn't been previously validated. It was based on an existing checklist, but it was significantly changed, and it did rely on self-reporting. And there are some drawbacks with people reporting their own progress. It may have been used differently in the different sites, or it may have been influenced by the principals or other seniors who wanted the school to look good and so wanted positive results. We did not collect disaggregated data on diversity, either amongst the mentors or the students. And although we did collect qualitative data from the principals of the schools, we did not collect it from the mentees or the midwifery students. So in terms of the next steps, the virtual community of practice is continuing. But unfortunately, in Bangladesh last year, some of you may be aware that there was a change of government, significant political and civil unrest, and that also greatly affected the nursing and midwifery schools, where many of the principals and faculty were moved or changed, and that unrest is still ongoing at this point to some extent. We're also in between different funding mechanisms for the health sector. So we currently have a hiatus, both in terms of delivery of education and of funding. And so the site visits have not been able to continue this year, but thankfully the virtual community of practice is alive and well, and we hope that the site visits will continue as soon as possible. UNFPA continues to advocate to the Ministry of Health and Family Welfare for the creation of posts, jobs for midwifery faculty. At the moment, there are no actual jobs for midwifery faculty. They are all acting up from another role, so most of the midwifery faculty, their designation is actually senior staff nurse. And so we need to create those leadership positions for midwives and have dedicated faculty. We are currently undertaking a study with the University of Gothenburg in Sweden. As we said, one of the drawbacks was we didn't do a needs assessment of faculty development needs. That's currently being planned and will be implemented in the next couple of weeks, the data collection. So glad to say that we are now, future faculty development will be based on the needs that the faculty say they have. And then an exciting development is that this year, the International Confederation of Midwives will be launching its faculty development standards at the ICM Council meeting coming up. And so the work that's been done in Bangladesh has influenced and informed the development of those standards. So that's really exciting. Thank you. Next slide, please. I think we're just about done. Yes, we are. Fantastic. So these are our references and any further reading that you might like to undertake, including the study that Judith referred to and the study of midwifery faculty needs, which was done recently. So thank you very much indeed for listening to our session, for your interest. We really appreciate it. And I would give a huge shout out to Pronita, who coordinated this study and has been the driving force, and also for Judith and her team for the expert support and advice early on. These are our contact details, so do reach out to us. We should have some time for questions, but reach out if you'd like any further information. Thank you. Elisa, I think we're handing back to you at this point for questions.
Yes, thank you so much. So, any questions? Otherwise, yes?
Yeah, I think there was a comment there, Elisa, if you want to read through this, Kate Greenstock.
Yes. She said, so fantastic to hear this. I'm sitting in India where the structures are very fragile. So much to learn from you, and would like to hear more about peer mentorship. She said it at the start of the presentation.
That's great. Well, Kate,
yep.
we have written this up as a journal article. It's currently been submitted for peer review, and we're hoping it might come out next month. So watch this space. But if you'd like to read more, you hopefully will be able to read our journal article, which is able to go into more detail than we have been able to in this presentation.